and welcome to the next episode of Future Proof Physical Therapy. Today, we are honored to have Dr. Chad Cook on our show. So it is a great pleasure and a great honor, and I would like for you to introduce yourself. Not that you need an introduction.
Well, first of all, thanks for having me on. I've listened to a few of your podcasts, and I hope I can stay up. You all are in front, I think. So I'm a physical therapist by training, by clinical training. Right now, I'm primarily a researcher. I'm a tenured professor at Duke University, primary appointments in orthopedics, and that's where the DPT program is. I do a little teaching, but mostly research. I also have secondary appointments in population health sciences and the Duke Clinical Research Center. I dabble in a lot of different types of research, primarily health services research. I've been doing that health services research for about 27 years, and then I've been a PT for 36 years.
So awesome. And of course, my partner in crime, Dane, is here.
I can't wait to learn from you more, Chad, and hear more about your research and your perspective on the future of PT from the standpoint that you come at things from.
We have to find out what's in the Duke water because every time I reference something, it's either from you or from Trevor or from Kyle. It's always someone. You guys are just an amazing contributors to our industry, but I think healthcare as a whole in this country for where we are.
That's very kind of you. We do have a top-notch faculty that we've accumulated over the years, great leadership. I mean, it really is it's a fun place to work. A lot of freedom for people to explore things they're really passionate about.
Yeah, and we definitely need like your production, and we need everything that you have put out there. Right, has been so immensely helpful. I think we would be in a much different place if we didn't have your scholarship to support our mission.
That's very nice, but I think I'm one of hundreds of people that have done some great things, including you two, and how you connect with individuals. You know, researchers always feel like if you write that paper, somebody will read it. That's not always the case. There needs to be that bridge to the clinical population and to our patients. So this is why this is so important, I think.
It's amazing, and I would introduce your theory. So I think that this was actually pretty awesome that you had an initiative to let's look into these 5 things that physical therapists think they need that they actually may not need. So the framework is going to be pretty simple. Each one from our own unique domain of expertise is going to look into these 5 systems or 5 things that our industry believes is absolute of necessity that may not be so. So I think we'll just hit things off with you, Dr. Cook and Chad. Like, go ahead and tell us what are your things, and we'll kind of go one by one.
So all 5?
Let's go one at a time.
One at a time. Okay. I'll start with the fact that we are considered movement experts. And so I want to first obviously preface this by saying I understand why the profession went in that direction. You know, I think it has a lot to do with identity and carving our place in our space as specialists, which I think is really important. I will say that I don't necessarily think that reflects what we do as much. I think we do other things that are probably a little bit more important. It concerns me that we're also trying to push some initiatives that haven't stood up that well in science too, like looking at movement dysfunction and whether, or the way a person moves and whether that's related to a pathology or a trajectory or something like that. So those are concerns I've had around that. Again, you know, I don't want to take shots at anybody. I know they're very passionate about this, but it's we're so much more than just movement. And hopefully, and you know, I've heard you two say this in either your writings or past podcasts, you know, we are really partners to the patients. We are there for their transition. We are there to help them in their journey, and movement is a very, very small piece of that.
Yeah. And I think that by labeling ourselves movement specialists, we were creating either or framing, right? And that framing almost pigeonholes us into a very specific, secluded part of the industry where there's so much more. And movement is just part of the larger ecosystem. Maybe movement is just easier to digest. So I think it's like when you need a label, your industry label, movement becomes approachable because it's not threatening. And we're very non-threatening industry, so we don't want any adversity. We don't want any controversy. So movement it is.
I mean, I agree with you, Chad, that the labels that we give ourselves, that our association gives us, can limit our own thinking and become a self-fulfilling prophecy. Movement is something that can be difficult for other providers types, other clinicians to identify with. So if we say we're movement experts, what does that mean? If I'm interested in partnering as part of an advanced primary care team, and if I say I'm a movement specialist, well, who does that mean that I triage first rather than the PCP having to, or the advanced practice provider? I'm curious what you might think about identity. Is there one term or one describer for physical therapists? And if not, where do we go?
Yeah, and I've thought of that. I actually thought that might come up today as I was working during the day. What would you call yourself? And I'm not sure what it would be. So I have a colleague, he works in the VA, and the physicians have told him, because the physicians kind of mentioned that, you're labeling yourselves as the movement profession. He goes, what you ought to be is the Swiss Army knife profession, because you do a little bit of everything. And whenever we don't know what to do, we refer them to PT because they get it sorted out.
I
So
love that.
if there is a label, I think it's the Swiss Army knife profession.
We did a thought experiment. So at one of the conferences, Drew Contreras and I were like doing this like thought experiment about what would happen if we just completely implode the entire industry, just start from the ground up, and you get away from physical therapy as a name, because I don't think it's even a good name. It's what we do. It's not who we are. What kind of a name would you give this discipline? Something similar to what podiatrists did in like early 80s. When podiatrists were chiropods, right? And
Right.
then the practice was very small, very nichey. And then someone, I think the leadership figured out, like, we can align with AMA, we can become podiatric physicians, and they became podiatrists. And that just by changing the name, their entire identity changed too. But what would be that name for us, right? Is it Army Knifeians?
That's not going to work. I think, just to go back to before we introduced this, I think, or maybe when we just started with this question, you mentioned being specialists. And I think that is almost as damaging in some ways to be thought of by the medical professions and by policymakers as specialists. We end up getting bucketed into the specialist category and taking, especially in the last 5 to 7 years, taking cuts in the physician fee schedule because the cuts have been made generally to specialists, where the behavioral health and primary care specialties for physicians have benefited from those shifts in additional codes, RVU weights, et cetera. And while the point I try to make around this is that physicians have specialists in primary care and behavioral health has specialists in primary care, but somehow we've labeled ourselves, or we've been labeled or accepted the label of specialists, yet we have primary care PTs, and whether or not they think of themselves as that. And when I was doing home health, I was thinking of myself as a primary care Swiss Army knife solving problems, right? And we have lots of specialists, and it doesn't take away from either of them to have a primary care, not designation necessarily, but to be thought of as part of the primary care team is now worth gold. And how can we pivot that? And just curious what that brings up for you, or if you agree or disagree, feel free to push back.
No, I do. I think a majority of well-trained PTs who truly care about their patients have to work with a primary care lens, because you can't just look at movement or your little narrow area that you would normally, or something that I did 30 years ago when I didn't know any better. The advancement on what we do and what can make a difference for a patient has to include those lifestyle medicine components and other factors that some educational institutions train well, I think some don't. But yeah, I think primary care is essential. I think, being a behavioral coach and being a partner with that patient on their journey, I hope we get a chance to talk about the fact that our current care models are really not designed for optimal recovery. It's too short, too fragmented, etc. But all of these things, I think, are considerations as we grow as a profession and as we adapt.
I am of the NIAMT background. So I'm NIAMT.
What does that even mean, NIAMT?
North American Institute of Orthopedic Manual Therapy. It's James Syriac's original, like, old school C-bone, crack bone, like PIVMs and PAVMs, so like arthrokinetic movement assessment, and like being that hyper specialized diagnostician of
Yes. His
segmental
book is right
dysfunction.
there behind me.
But yeah, no, it was awesome. Like, and actually, like, if you talk about psychology of well-being, like, I felt great when I thought I could diagnose a segmental dysfunction. I feel like shit now because I don't think I know anything. But 20 years ago, I was like, yeah, like, bring it on. Like, any dysfunction was mine to have. So I think that tissue specificity, we almost need to
Yeah.
feel like we want to have it, but
Yep.
we
It's a
don't.
really good one.
Right. So you're absolutely right. So Chad, what do you think of it? Like, I have these conversations with younger like, with younger PTs, and it's almost like that you get that blank look, like, how dare you question my ability to identify this? And it's like, well, you just don't.
So it's a two-step process, and the way that we've taught it and the way that we've written about this, I think there are some instances where understanding what you're dealing with, the lesion, and then I'm talking mainly about red flags, that part of it, the specificity of that assessment is actually really important. And there's where the investment should go into the training. The second phase, where we're trying to differentiate different types of rotator cuff lesions or hip lesions, in many cases, it really doesn't seem to matter. And the care overlaps so much that you end up doing essentially the same thing regardless of what label we give it. So I'm a believer that on the front side of it, it's important, the big scary things, can we distinguish those? Can we rule those out? But on the back side of it, the amount of time and testing that we've invested in the past, the 56 different SIJ tests and all of the rotator cuff tests that you had to learn, memorize, et cetera, know the sensitivity specificity values, probably doesn't matter that much for what we do with those folks.
Do you think it's a Picasso effect where you have to learn to draw like Rembrandt before you can draw like Picasso? So you have to learn all of the special tests and all of the tissue specific diagnostic clusters before you can actually say, like, well, now it's relevant.
Yeah. And I see that you see a light bulb go on in people's head. I think those that have really wedded themselves to the specialist. So 20 years ago, we wrote a textbook and we put numbers on the tests and we said these have high utility, these have really no value. And wow, it was like we kicked puppies, right? The people that were so passionate about a particular set of tests. I actually at the time, I wrote a editorial called "Emotional Based Practice." I mean, people were just absolutely wedded to tests, and it took a while for that to separate. And other people jumped on. Other people did some really quality work, but it really boiled down to the fact that we're not that good at differentiating tissue lesions anyway. Our tests are not that good. They either rule out or rule in, or neither, and there are a lot of neithers. So that part of it, I think we need to train, especially new learners, to really deal with the gray. Unfortunately, I think a lot of people come out very black and white. It's either this or this, and if I don't know what it is, I don't know how to treat it.
Yeah, you want to be correct when it comes to the tissue type and how to manage that tissue, but to be so exacting. Now, the other point about this that's, just reality is payers don't care. They don't differentiate. And they're not paying us differently because we figured out it was this tendon versus that tendon. They just want to they're paying for a service and hopefully we get to paying for outcomes, but they're paying for a service and a visit. And they're not going into the weeds. I couldn't agree more. But you're putting into words, I think, something that a lot of therapists struggle with, but then feel like the kicking the puppies example, like feel like it's sacrilege to say maybe that doesn't matter as much as we think it did. And if it doesn't, then what else should we be doing? Right?
I've got a follow up on that if you don't mind.
Please.
So we've done a lot of work around contextual factors and those ritualistic interactions that occur with the patients. Sometimes that little ritual of trying to isolate it and giving it a label and whatever is really important to the patient. So I think it's really understanding that person in front of you too. And instead of saying, I don't know, it could be this or this, instead saying, basically all signs suggest this. Great. It's what we treated 1,000 of them. You're going to be fine. Let me tell you what you can expect over the next couple of weeks, etc. Yeah.
I think that's spot on. So I just had a conversation earlier today with this health tech startup, and I had to coach them that they have to have two different types of script. One script for precisionists about the actual mechanism of
Hmm.
their technology, how it works. But then they have to have a commercial script that appeals to the commercialist, that have to, like, how do you monetize it? Like, you just have to talk dollars and cents. And it's bipolar in a sense, because one sometimes contradicts the other, but it's almost necessary, because without that bipolar philosophy, you will fail by being only a precisionist or only a commercialist. So it's that pathos over evidence, right? I think we are guilty of always applying emotion to where evidence needs to apply.
Yeah, it's hard to divorce yourself from your training.
Mhm.
It's something you sunk so much time into, like NIOMT. I mean, that's not an easy training.
Mhm.
There is a lot of memorization of different movements and joint and patterns and things like that. That's a hard, when you pull yourself away from that and say, that's not really how I believe or how I practice. That's a tough change, I think, initially.
Absolutely, but if your identity is so homogenous, then I think that may be time for you to start taking different classes, and that's also, and I want to see what you think about it. But we have this indoctrination into the philosophy that tends to be our primary flag that we carry for the rest of our careers. So you become the therapist, like the Maitland therapist, the McKenzie therapist, the biomechanical therapist. Which, like, why does it have to be like that? Why can you not be this and that? Why can you not be a pain specialized therapist, but also be a McKenzie therapist, right? Like, what's with these, like, identity labels?
Well, I mean, you bring up a really good point. So we studied that in the mid 2000s, and interestingly, 91% of the people who regularly used manual therapy gave themselves a label as one of the disciplines, and only 9% called themselves eclectic. That they used a lot of different approaches. And I think, I mean, personally, I
Unbelievable.
think the number's probably a lot higher now as far as who consider themselves eclectic. I think people tend to, when they train, they move toward a system that probably reflects their thoughts a little bit more. Or some people just fall into a training pattern and go with it because they've already invested so much in it.
That's what I was going to. Perfect transition. I think it could be as simple as sunk cost fallacy that exists in so many other parts of life, right? If you've to have to go back and now question what you've been doing for maybe 10 or 15 years because you're considering either integrating other approaches or a different approach, or you're open to the shortcomings of your approach. That's hard to do from just a human psychological perspective.
It's a loss, right? I
Right.
mean, you actually experience, and I think a lot of people grieve that separation of who they were and who they thought they were, and then until they actually, I think it's actually one of the reasons we run into burnout and a number of other things in our profession is people have a hard time. They want to connect to something that really makes them special and make a difference. And when you deal with such grayness and such, yeah, it may be not, it may not be this is the reason why they got better, or those are big changes.
I think that it is, but in a way, there's also a risk that when we start to associate with one specific skill being a dominant skill associated with our profession, we cluster ourselves into this very small niche market, which does not allow us to escape this market. So we become, well, he or she has really good hands, or he or she is really good sports therapist. You in a way, if we are going to be like an, I think there's a dichotomy in a movement versus mobility. We can be mobility specialists without being movement specialists, but if we can enhance individual mobility through specific progression, we can afford to be both, right? We should be both instead of just being really good therapist or really good manual therapist.
One last thing on the labels and going back to our original, what should we rename ourselves? I've, I have, I'm sure you guys have the same experience with friends and family who have an issue and you're the closest thing to a physician and they trust you. So they ask you a question that's maybe not really related directly to PT, but we have so much education and experience. And if we've done some additional studying, we understand meds really well and we understand, how conditions are managed and we know how to look things up with a, smartly, and we can help with direction at least, or to say, yes, this is probably just let me hear about it. sounds like it's not really a PT thing, sounds like it's a medical thing, whatever it is. I've thought often about what's different about us from physicians when it comes to managing someone's condition or set of conditions longitudinally is we don't treat with medication, we don't treat with injections, we don't treat with surgery, but we do everything else. And that includes, right, coordinating, evaluating, managing, educating, coaching, engaging, all of those types of verbs are skills that we have to embrace because there's not a lot of other professionals in healthcare that are as good at that as we are. So now that is so not succinct and that is not giving us a better label, but I kind of do think of us a bit in terms of what differentiates us from physicians, yet is similar, because I think the more we embrace the fact that we're a doctoral level professional and we can evaluate broadly, the better it is for us. And we can refine that.
Well, Dana, I've heard you use the term transitioning. And to me, one of the most important things we do is transition from a therapist that works with you to heal you to transition that person to self-management, where they're taking care of themselves and we're motivating them. We transition to a health coach at that point, or a lifestyle medicine expert.
Yeah.
I would argue that that is the weakest area that we're trained, but probably the most important area we could train in and build that part up, and one of the most challenging that we know the least about. To me, that's the direction we need to go. Like, we went in and completely revamped a curriculum and said, okay, we're going to make the new PT. Well, that new PT is going to not receive a lot of older trainings and then invest more into learning how to transition folks to being independent and transitioning people to understand what normal setbacks look like and how to manage those and that sort of thing. I don't think we do that very well, but I also think we're in a health system, a model that doesn't allow us to do that very well.
Yeah. We're not paid to do that in fee for service.
I think, like, considering the ambiguity and the cost that we charge for, you can claim anything you do. I think we do enough hokey pokey pseudoscientific stuff and still get paid for it. Might
but
as well.
not paid well enough is the problem.
But this was one of the bullet points, and you're like, it's the focus on specific types of treatment provided. Most people, especially those who have long-term issues, are debilitating and initiation work. So I think it's the treatment effect and the treatment specificity. How do you package it? How do you frame the lack of specificity as something of value? People, as we just spoke about, right? People like these specific labels because there's a direct association of labels to value. And if you create more of an ambiguity, like, we just need to see each other because I need to manage your progression of load transference and your tissue habituation, which will take 6 to 12 weeks, and we're going to have a good time because you like me and I like you and we've aligned. You can't sell that. You have to be like, well, we're going to give you very specific phase 2 recovery protocol based on this pseudoscientific literature. So what do you say about that?
Well, there's a lot to say about it. And so first of all, I think there's a therapeutic ritual effect that we don't fully understand, where you can do almost anything initially, and it's going to make a pretty big difference with the patient. And it likely has just something to do with them doing something. And so that's one of the reasons why our therapists who tend to throw anything at somebody still see some changes in those patients. A lot of the folks that we see are so unhealthy and lack any form of activity that just a little bit seems to go a long way. And so, do we need to be so detailed about it? Do we need to prescribe a really finite resistance-based exercise program? I mean, eventually, probably, but initially, it's probably not going to matter what you do with them. And that's essentially what we see within the literature when we compare this treatment specimen versus this treatment specimen. It's the same. The outcomes tend to be the same. I think contextually, if you package it as if it's some sort of special, this is really unique for you, it's patient-centered, just for you, nobody else is doing this, it's going to mean something to the patient. And like we just talked about earlier, the real key to this, I think, is changing the behaviors of the patient. And that's the part we don't do very well, is at that 6-week mark, when the person tends to improve, what do we do at that point? Just let them go? And yeah, you're on your own.
Goodbye. I'm tired of you. You were fired from my care. I never want to see you again. Please
Isn't
leave.
it just crazy?
It's crazy because that's probably the most important transition part, right? That's
Totally.
the part when we need to say, hey, this needs to be lifelong. This is where you can take this and continue to do this on your own. And that just doesn't happen very often.
Okay.
So I just finished a very short episode of Health Tech Nerds podcast on a company called Bold. First of all, shout out to the Health Tech Nerds podcast. It's excellent. Their group is awesome. But so Bold is, if you've never heard of it, I hadn't, so I'll tell our listeners, it's some kind of digital health tool or an app that is sold right now to health plans. It's going to be in the access model. They were accepted. They're super enthused about it. And the goal of Bold is to take essentially those who do nothing, no engagement in exercise or movement or some kind of physical activity, and get them from 0 to 1, and then go from there. And that the biggest effect size is in that 0 to 1. And the CEO talks about one of the goals is to reduce necessity for physical therapy or the frequency, and they want to partner with therapy. But again, we've talked about this a bunch and written about it. Therapy, it does have to recognize that there are disruptors who see these flaws that we're calling out and have solutions and have building solutions, and they're ready to deploy them. And they now have an avenue with new payment models. And I mean, I know we sound like alarmists, but it is because we're alarmed. The need to pivot in the way that you're describing, Chad, is important.
It is. And Alex, I know you've talked about this before because you've talked about hybrid rehab. And the backside of hybrid rehab is digital AI generated interactions, engagements that are meaningful to continue to work toward that behavioral change. And when I say behavioral change, I'm talking about being active, doing things that are healthy, lifestyle medicine components. And that doesn't need a therapist. It can have the oversight of the therapist, but it doesn't need to have somebody doing a 30-minute telehealth visit or anything like that if the engagement interactions are actually meaningful. So, obviously I'm less scared. I'm near the end of my career, but I actually kind of like these changes that are happening. I think they're happening for a good reason. And let me throw some numbers at you, and I know you all
Please.
know these. So there are studies that show that 75% of the PTs or patients who receive a PT referral never even initiate that first visit.
Mm-hmm.
And so that's a huge 3/4 of the population we're missing because obviously the model isn't right for them. And then the second piece is, in our studies, we've shown that up to 30% of people drop off after that first visit. And a lot of reasons, well, there are a lot of reasons, but cost and access barriers are a big one. But the other thing is they just don't connect with their therapist. They're not on the same page. We did a qualitative study on that. So when I think about these alternative programs that are coming in, my comment is this: they're going to capture that population that we've failed to pull in.
Sure.
Yeah, and good on them.
Yeah.
I hope they do.
Yes.
And I hope we're smart enough to join that and make the changes that we need to make, because I think we could really do a good job with that.
That is the alliance. So I think if you look into the optimal models, digital entry into the healthcare system it's the best entry because it doesn't have a constraint of accessibility. You can enter the system. We all have these, right? We all are walking around with these smart devices. That's your point of entry into the health system. And there's a lot you can do with this technology. You can stratify risk. You can identify opportunities. You can reduce uncertainty because there's a pretty large pattern of behavior that's predictable. And once you determine your basic need, you can create choice architecture for the transition points, right? The transition points can be determined based on economics, based on access, based on geography, based on epidemiology. If we have this epidemic, like all of a sudden tomorrow, everyone wakes up with a rotator cuff tendinopathy and we don't have enough therapists, like we can start to, right? Like, oh no, like it's a pandemic. But I think the digital point of entry, the way I see it is that we're just early to the game. These digital systems have figured it out, and I'm on the same page as you 100%. I think good for them, and not only good for them, but I hope there's more of these models that are going to take legacy business away, because it's on legacy business to give people value. If they're failing to provide value, then it's their fault. but it's about alignment of knowing when to transition. These systems also need to then be optimized to understand when the level of chronicity or the level of urgency dictates a face-to-face interaction or a live interaction.
There's so much to learn. I mean, and we don't know that optimal model yet. We don't know how to tailor it to the right individuals. We don't know the best back end digitized experience for the patient. There's so much to learn. And this is where, I see funding agencies, doing this. Let's do a manipulation versus a mobilization, and we're going to fund you, going to give you a lot of money on that. And it's like, that's meaningless. And by the way, did that research before. All right. But there are so many opportunities to be funding some meaningful work. And I just don't see that happening yet.
Mhm.
I think the cart is before the horse. The clinical side is so far ahead, and the reimbursement side is so far ahead of the education side and the research side, in my opinion.
Yeah. That's brilliant, and it's an interesting time, though. I think to be optimistic, it's such a brilliant time to be alive. I think we're all more or less generationally similar, but the generation that's going to access healthcare system, that's only starting to explore healthcare system, is the generation that's primed for this digital first model. Like we're not digital natives. We're digital converts. We started without digital tech, and we kind of converted into it because it's convenient. The digital natives, the 20 somethings, 30 somethings, our kids' age, they're the ones that are going to slowly graduate to the need, because we know that musculoskeletal problems happen. Like you've done epidemiology studies, you've seen that it's going to happen whether you like it or not. You're going to have back pain, you're going to have neck pain, you're going to have shoulder pain, and you're going to pursue medical care regardless of the country you live in, regardless of the system. So these digital natives, I think it will be interesting to see in the next 10 to 20 years how these systems are going to adjust to higher volume and higher level of utilization. Right now, the engagement, the utilization is like 3%. So these systems that cover 100 million lives, 3% of that system, so 3 out of the 100 million, have actually engaged with the system at least once. And they don't even have the statistics how many continue to engage. So that's just 3% that plugged it in, and that's it. And then maybe like whatever percentage of that actually continues to use the system. But I think it's going to change when instead of 3%, you're going to have 25%. And then from that, you're going to have higher retention. How is that system going to evolve? And is there going to be an economic incentive for that system to say, like, well, I do have these partners in the legacy side that can align with best practices. They can give you concordant care.
Yeah.
So I'm taking a course right now through Harvard called AI in Healthcare. And I know a lot of people are afraid of what AI is going to do and how it's going to potentially negatively influence healthcare. I actually think it's going to be positive.
Me too.
I think the ability to have a front end kiosk to drive people to the right care, to reduce this lack of continuity between providers and the handoff problems that we see, especially in the VAs. And then on the back end, I think AI is going to play a major role. And what's interesting is just being in this class and listening to the people who are truly making a difference.
Yeah.
And it's already here.
It is.
There are already major changes that have been made that I wasn't even aware of, especially in imaging. And it's improved things so much. Alex, you said it's a kind of an exciting time. I think it's super exciting. And I'm very optimistic that it's actually going to get better. Why wouldn't it? I mean, one of the statistics I wanted to share too is if you look at the research on how we're doing overall with our care models, for the last 2 decades, our patients with musculoskeletal problems have actually gotten worse, not better. Despite all of the millions that we've sunk into research and all the clinical practice guidelines, et cetera, we haven't improved. We've actually worsened. And it's likely because our patients are sicker, but it's also likely because we haven't figured out that our patients need something different. And this different is what I think is so exciting.
The one pushback on the 3%, because we've seen that statistic in Peterson Health Tech Institute studies. Remember that that's studying like something that's supposed to be considered a more direct alternative to PT. So the Hinges and the Swards, they don't have a very high percentage of the population engagement. But when you talk to organizations that are also digital health, but aren't as blatantly PT alternatives or PT supplements. And they've really been essentially supplemental benefits offered outside of the medical benefit. But this is this example of Bold. I think Withings is doing something similar. they're more after the gap that's less direct between how to engage, how to naturally get a patient to do what we know is going to reduce costs and make a significant change. I think her example of we just want to get people who are unhealthy to begin moving in the simplest way. The way, this is a guest on a podcast, so she's just sharing what she's sharing. I have no evidence to suggest yes or no, this is accurate. But she's saying, look, we're so excited about access because where we are contracting with like full risk providers in MA or MA plans, the physicians are getting such a pushback from their fee for service patients who want to access it, but don't have it as a supplemental benefit in their MA plan and can't. And so now we've got this solution ready to go. We have a mechanism. And now this is the beginning of us having this, both Medicare Advantage and Medicare channel. And they only have done Medicare, or at least that's where they started. So they're not concerned remotely about a low engagement, but they're not looking at it as sort of like a light PT. They're looking at it as we got to engage patients because they're really unhealthy and they're missing things like basic mobility.
Yeah. It's right on. And I think even if you guys need a company, at least that I'm enthusiastic about, Armada Health. So Todd Norwood is a PT who is in Armada Health. So it's a system that built a musculoskeletal channel using real world evidence in a musculoskeletal field. So they were able to create a digital infrastructure using at least best available evidence for these pathways being designed. So there's still a fair amount of automation, but there's a human in the middle that's designing these systems, unlike some of the other systems that may design a system that's pretty and that drives engagement, but like TikTok drives engagement. My kids will attest to that. But it's not necessarily a system that it drives positive engagement, right? And I think there's a lot of movements-based engagement that needs to be more nudges towards autonomy and not just towards self-sufficiency, which you were referencing, Chad. Yeah, so let's move to a next point, which is a session by session symptom fluctuation, essentially flare-ups, and this lack of patience within our industry that we treat flare-ups as something that's menacing, and we treat session by session fluctuation without seeing a larger picture of these recovery trajectories and longitudinal recovery trajectories. So how do we adjust to that? That like it's more like this, not this, right? That matters.
Well, I'll take a shot at that. So we've done a lot of research in this area and around like early change and whether it's meaningful. And early change that isn't a big change isn't very meaningful, but early large change, where you're looking at maybe a third of the levels of dysfunction or pain, does have a very strong trajectory. So that piece of it, I think, is worth looking at. The key is the threshold there. There's work from Adam Lutz, that looked at treatment signatures, and what he found, and you all may have seen this before, I've talked about this before, about 80% of the PTs do just a hodgepodge of collective stuff, and they all have very similar outcomes. And then another 10% has really poor outcomes. And when they looked at those signatures, they were given exercise only. There was no manual therapy associated with it all. It was this kind of the same exercise program, regardless of how the patient presented. And then the top 10% were those who actually adapted their care depending on how that patient came in. So if the patient had a setback or something like that, they adjusted. And they also had higher percentages of manual therapy, not manual therapy overuse or just manual therapy, but manual therapy in addition to an active approach. And those had were in the 10% had a solid, significant improvement versus those other groups. So I think it's important in some ways, but Alex, what I agree with you with is we can't lose sight of what long-term trajectory is. And I think that's where we derail, right? Somebody comes in, they have a setback, and we completely lose the focus of what we need to do to manage this individual. Instead of walking through that setback and saying it's temporary or whatever, we lose that common vision that we negotiated with the patient in the first place. And we go all the way back to square one or something like that. And it happens a lot, I think, in the way that patients are managed. I think the really strong clinician can both adapt their care with that patient in front of them, but not lose sight of what long-term that patient needs. And that needs to be the conversation coming from that clinician.
Yeah, so much of it is what you were just referencing too, that a therapeutic alliance and that termination of care at 6 weeks, because we believe that that is the threshold that you need to terminate care, instead of like a plan of care should really be a contract for this episode of care. But a plan of care should entail at least 12 months of recovery through variable systems, through digital systems, through independent systems, through maybe 12 months of recovery. Then you should consume some behavioral health because you have a primary behavioral driver to your condition, and that's your but I think for that we need to align with other medical disciplines, which we also, but perhaps that was should have been one of the bullet points for 5 things, that we just don't play well with others. We play well with each other, but we don't play well with other systems, and behavioral health is a major system that can take over a significant carryover, right? There's just a conversion from what we do to what behavioral health does, and vice versa, right? Go
So
ahead.
what's not in this list either is the importance of establishing a prognosis with a patient and having you align with the patient on what that rehab prognosis is and connecting it to their other health conditions. And this is why it is so important that we have this at least semi generalist philosophy that we can incorporate whether or not a prognosis makes sense given the complexity of their other health conditions, just whatever they're coming to us for on top of that, or are they, potentially just have expectations that we're never going to meet. And by heading that off early and working together, and this is one of our, should be flexing the skill set, is our communication ability to work with a patient, establish that prognosis and continue to work towards it, but returning to it to remind each other about it, to modify it if we need to. But if we have these ongoing, like maximize the number of visits philosophy without thinking, what is the long-term objective and prognosis for this patient's pain, movement, dysfunction, whatever it is, impairment, and what is going to be sustainable. And then what is the plan to get to that based on that prognosis? You hear a lot about goals, but boy, I've spoken to therapists all over the continuum about prognosis, and they look at me like I have 3 heads. We don't do that. Well, of course we do that.
I mean, like
How,
goal setting.
how do we make a plan if we're not thinking about what the capabilities are of achieving whatever these goals are and getting from here to there? But more than that, sustaining it. Because if we just achieve something, but it's not sustainable beyond a X period of time, what was the point? And shouldn't we be focused on that piece more?
You all might remember when the medical profession was grasping with this challenge in the late 90s, when Donat and Croft and several others were publishing papers saying there should be equal amount of intensity in education on prognosis as there is in diagnosis. And then that would reduce the amount of overtreatment and
Yep.
medicalization and everything that we see. I mean, so there are several models out there, right? Like Taylor Care has a really wonderful, they have a navigator essentially that they look at high risk individuals, they talk to those patients, and they give the patient an understanding what the prognosis likely is based on their condition. And the patients can then make their decision on what to do. To me, it's not anywhere any different than having a car problem, going to an auto mechanic, and the auto mechanic comes out and says, let me tell you what's wrong with it. This is very fixable. It's no problem. We'll have this done in no time. I mean, the relief that, for you as a consumer, it's the same thing with the patients. They're looking for someone who can tell them, this is what you can expect. This is how long it's going to take. And you're going to be fine. Sometimes that's all you need to do the nudging to behaviorally move them where you want them to go.
I think a reduction in uncertainty is certainly a huge one, right? We actually create more uncertainty by creating these pseudo prolific claims and labels, or allowing people to assign their treatment to their recovery rather than their agency to their recovery. Like, you need to be here 3 days a week for the next 84 weeks. So that you need another 300 sessions for us to work on your problem instead of working the other way. But I think there's also a point of that maximizing or satisfying. And we're maximizers. I think as an industry, physical therapists are maximizers. We see everything or nothing. You're either better or you're not better. And we don't see more better or less better or betterer as a viable option. That you can't be betterist, but you can be betterer. And it's hard, it's tough, especially teaching students or teaching kids to the like some patients will leave you feeling worse, but actually being better for seeing you. How do you teach that, right? That you will have a suboptimal recovery for this patient, but you planted enough seeds where in a year this individual is more likely to get better because you've done everything right. You've created a more of a behavioral safety map versus you did all you had to do and you instilled this passive coping system on that individual, and then a year later they're still under your care because you're still working on reversing their postural misalignment.
So, I mean, you bring up a great point, and isn't that where true expertise lies? I think is the ability to. So, on one of the first slides I show my students, I teach health systems at Duke, is I have a slide from Elon Musk, and I said, you're going to have at your fingertips all the knowledge you'll ever want, and that used to be what academia was about, right? We would impart our knowledge on individuals. Well, knowledge is all out there now. You know, go to ChatGPT and pull it. The key is understanding the context of that knowledge and what actions to do with that. And that's expertise. And that's what we should be training our learners. That's what a residency program or a fellowship program should really focus on is, okay, let's talk about how to address this and how to manage this and how to get the person independent. And I don't think that is emphasized that much, unfortunately, because it's hard. It's hard to teach.
Yeah. Yes, yes. But at the same time, hard things are good, right? Like, who wants it easy? Remember the diagram, like hard, fast, or whatever. So let's move to the next last best point, which is, as you were referencing before, the exercise, like the exercise intensity and our indoctrination that exercise intensity and exercise volume is somehow proportionately aligned with exercise quality. And so when I teach students exercise, I tell them that exercise is the worst label you can put on it, right? It's like we exercise as a culture, we see exercise as like sweaty in a gym, lifting heavy stuff, instead of exercise as a point of tissue specific adaptation that happens over time when you apply load to it. And so maybe we need a different name or a different label, but how do you think we can transition therapists from moving away from you need to exercise and almost fear mongering that did you do your home exercise today, and then exercise shaming that, oh, how dare you, like you betrayed me, I fire you as a patient, you're discharged because you didn't do your home exercise program, instead of just instilling more of an active lifestyle.
Which is the most important thing, right? I mean, which is what we really ought to be. That should be the focus, and whatever vehicle we use to get them to do that should be the vehicle we use to get them to do that. And you know, I pointed this out initially because, you know, I used to be on social media a lot more, and I used to, you know, jump in and see the arguments between, you know, you should be doing deadlifts. No, you should be doing, you know, whatever. And to me, it was just so senseless that, and the next question would be, well, which population are we talking about? Because it's certainly not everybody. You don't need to do those things with everyone. It's not that important. What really is important, though, is convincing the patient to continue to exercise or whatever you want to call it ongoingly and changing their lifestyle. And that part of it, that's where your contract with the patient should be. That's where your emphasis should continue to be. And that's what we should study to really understand what do those strategies look like. And, you know, you all mentioned behavioral specialists before. I work with, in 2 grants right now, I work with 3 different psychologists. And it's been the greatest relationship to work with them. I just love the way they think. You know, everything is about changing the patient so that they own what they do. And it's such a mindset differential that it's grown so much from those interactions. It's been great.
No,
Awesome.
I think that's, but that's the key, right? Is that understanding it's the complexity and how do you connect the nodes. Like, so seeing a psychologist worldview being dipped in the profile of their training, and you've obviously acquired enough from them. What do you think they've acquired from you as a academic and a scholar in physical therapy world? How do you think they were able to get some of your knowledge and translate it to behavioral health?
Yeah, so I'll answer this 2 ways. The first thing is I've had a couple of them say, you're very lucky that you can put your hands on your patients because that's such a powerful thing. And it's such a alliance building thing. And they said, we don't really have that, but you do. So you can use a lot of our strategies, but you have your own that are really meaningful. And that relationship that you build with your patient is really meaningful. And these are, I mean, these I won't say their names, but you'll recognize the names. These are top US level psychologists. I've had another one that say, you do realize that a huge part of what we do is therapeutic ritual, that it's all, that if you actually peeled away what is actually happening, there isn't much happening, but it is making a difference. And, that part of it, if you can continue to build on that piece, that's going to be really meaningful. And he said, you, again, being a PT and being there for those patients, spending time with them, engaging with them, going through the movements with them, those are very important things. I think those two things have resonated with me most, Alex. I mean, but they see us as like hands-on psychologists,
Hmm.
I love that.
which is okay. Yeah.
And touch. I mean, I think you've probably landed it. The most important thing about touch is not even the specificity of a touch, but the actual physical touch. But like, how privileged are we to have this already cultural acceptance of us having the liberty to apply physical contact with other patients, with patients without a scalpel, right? Without some kind of a menace. Like, we actually touch without hurting, objectively speaking. That is a privilege that we don't practice, and that's why when you have a drive to move away from manual therapy, because it's obviously it's passive, and like at the core, I'm a manual therapist. I think the reason why I do manual therapy is different, and the way I explain it is different. But you do have to touch patients. You do have to come in physical contact. You can't just count repetitions as the only way, because it may be at the level of care provision we get to touch patients. So if you're providing a digital first system, obviously there's no touch until robotics moves advanced. So hopefully your AI course will show you what the next 5 years will look like. But beyond that, do think that touch is such a privilege that in a clinic, if you do have a patient and you don't come some kind of a physical contact, you're providing inferior value to your patient.
I mean, there's so much to this, and I could go on and on. I'm not going to, but if your listeners want to read the work of George Estevez out of Malta, he's done so much high quality work on therapeutic touch and meaningful work. I have this story that I tell. Um, it was back when I was in my 30s as a PT, and this young lady who was maybe 4 years older than me had a brain tumor removed and massive epileptic seizures to the point where she could barely walk, had a lot of spasticity, really started stiffening up her joints and everything. So she would come in and see me, and I would work her legs and walk with her and do things with her. And she just kept coming back, right? And I'm like, I think you're independent. We're going to send you home. Um, she had a really difficult social situation. Her husband left her, all of these things. And then I asked her one time, I said, why do you keep coming? We're where we need to be. You're ready to transition to the next side. She goes, this is my favorite place to be. This is, where else would I go that people would treat me the way they do and just connect with me the way they do? And I think that, I mean, we unfortunately, in some cases, are the social component for a lot of our patients. Now, I'm not saying that we should capitalize on that, but Alex, you said it's a privilege, and
Mm-hmm.
that's what I tell my students. I said, you don't lose sight of how privileged we are to be in this role, and once you do that, if you lose that, you've lost that spark to be a PT, I think.
Yeah, it's essential. It's an essential part of larger professional etiquette, and we can't lose it. We shouldn't lose it.
So
So,
powerful. I love that another profession called that out because of, it seems obvious, but, it's so true I mean, I'll go to a physician and have them not touch me, even if they should be doing a physical exam, but it's part of it is expected of us, but it's also part of, building that partnership and that trust with patients and others. There's very few that have that privilege, like you put it. I think that's just such a great call out. There's no black and white, and it's
Think,
that's just such a good, important point to remember.
just
It really is a
think
privilege.
it is, and think how many times your patients have told you you're the first person that's actually touched
Yeah.
that area.
mhm.
You're the first person that's actually poked it. And I said, are you serious? And you've been through this gamut of providers. To get to me, you must have jumped multiple hoops. And I'm
Mhm.
the first one? That's not good.
Yeah. So in a way, like we were talking about validation from diagnostic labeling and validation from creating a more of a cohesive plan of care. I think touch is validation too. Touch is recognition that you are here and you're valid and I'm going to take care of you. So that's also part of that alignment. Even if it's a non-specific touch, right? Even if it doesn't adhere to one specific philosophy or that is superior to a different philosophy.
Totally agree. And it's unexpected, right? I mean, I would have never thought getting into this profession that the little things like that matter so much, but they really
Hmm.
do.
Yeah. So what would be the one takeaway for you that you would want to leave here that anybody who will spend the time listening to us would take with them and apply it to their daily principle, daily logic, daily ritual?
So I'll take less than a minute, but I want to tie it into something that it really connected with me the other day. I'm writing a paper with some colleagues out of Italy, and it's a qualitative study that basically interviewed individuals with fibromyalgia about their relationship with exercise. And it's funny because they use the term frenemy, right? Exercise. They exercise, they
Yeah.
know it's good for them, but it destroys them. And one of the individuals used a term, negotiated behavioral change. They said, that's basically what I want my healthcare provider to do for me is a negotiated behavioral change. And to me, that's kind of what we do. And, find out where they are, meet them in the middle, find something that is going to be impactful for them, and then see if you can help them sort it out. So I'll leave with that. That's, I think, impactful.
Love it.
Perfect.
Dana, what would be one thing that you would want the audience to take from this?
This is coming right after we recorded with Trevor Lentz, and I see a lot of similarities in how you think about the aspects of therapy that clinicians that are practicing maybe don't think about, the role of behavior change and the things that we maybe take for granted, and how to look at the gray as, something that we can lean into and flex. And what makes us special is maybe not always what we think it is, but it doesn't mean it's any less powerful. And if we embrace what's powerful, even if it's different from what we historically thought in our sunk cost fallacy, there we go, we can actually elevate the profession to what it has the potential to be. I say that and write about that quite a bit, that we have all of this like potential within this profession and this huge level of education, but we have to think differently about what we can contribute to society and to healthcare. And it is okay to think differently. The natural evolution of this profession is going to be led by thinkers like you, Chad and Trevor. And we hope to contribute just a tiny little bit through this podcast of, getting some therapists to hear and be okay with thinking differently about the profession and its direction. And it could be very positive.
Yeah, absolutely. I think both of you guys, whether you really realize it or not, in your own domains of expertise and your own
Yeah.
disciplines, you are the founding pillars of this modern musculoskeletal world. That I think anyone who follows us, you will build on what you have set in play and both of your professions. Daniel Lieberman, if you ever had a liberty hearing him or reading his stuff from Harvard, it's everything that's new is just a well forgotten old. And so we've been in this present shape for 1.8 million years. We've had this bipedal physiology and we've been in this modern cultural shift for about 10,000 years. There's a lot of these principles you can borrow from where we were without reinventing a wheel. Right? And everything I think we discussed even today is essentially what we are as species. And so alleviating discomfort, alleviating misery, and promoting well-being is what we do. And how we label it and how we choose to apply this discipline, I think is already secondary to actually alleviating some of the misery.
I'm just going to say, Alex, you are contributing such a tremendous amount to this profession and calling out and highlighting the work of such important academicians. Once you leave school, the translation of that academic work to those that are actually in the profession, I feel like it's just poor. It's improved a bit since social media and folks like Alex highlighting and calling out why we should care about it. But boy, is more of that needed, because otherwise, what's the point, right? If we're doing all this brilliant research and it has such translative potential, policymakers need to hear it and treating clinicians need to hear more of it, as do employers and health systems. So where we can be a tiny channel for that, boy, this has just been a very impactful 2 last sessions between you, Chad, and Trevor, and I really appreciate it's given me a lot to think about.
It's very kind. And Alex, I'm not going to lie. I thought you were a bot because your productivity is so high. I'm like, how does he get all this out? And so you're real. You're right there.
Yeah, like in living color, and like tonight is a tequila night, so it's a good night indeed. But both of you, thank you both for this, and Chad, especially thank you for. I've been following your work for so long. I thank you for being humble, and thank you for being the foundation of everything that we're going to build after. So, yeah.
Oh, that's too kind. I don't take compliments very well, so I'm just going to leave it at that. But
We got to take a field trip to Duke sometime, is what I'm sensing.
I'd love to have you there. It's
Cool.
it's a great place.
Well, thank you both.
Thank you.